Welcome back to the Explainer. You know that feeling, right? Waking up, you swallow, and boom, there's that familiar, scratchy, painful feeling. We tend to write it off as just a simple sore throat, maybe grab a lozenge or some hot tea, but what's actually happening back there is far from simple. Right now, inside that inflamed tissue, there is literally a massive microscopic battleground being drawn. And the culprits waging this war, they're vastly different from one another. We're talking everything from minor nuisances to aggressive, tissue-destroying assassins. So today, we're going to decode the mystery of tonsillopharyngitis. Okay, let's dive into this. Here's our clinical roadmap for today. First, the anatomy of a sore throat. Then, we interrogate the viral villains and mono, followed by Group A Strep's wrath and the threat of diphtheria. Finally, we'll cover the severe red flags before wrapping it all up with diagnosing and treating. Section 1. Anatomy of a sore throat, the scene of the crime. Before we can really understand the invaders, we have to understand the terrain they're invading, right? So tonsillopharyngitis, it's exactly what it sounds like. Inflammation of the pharynx and the tonsils. But think about the concept of Waldeyer's ring for a second. You don't just have one set of tonsils. You actually have a whole ring of lymphatic tissue guarding your airway. This includes the pharyngeal tonsils up high, the tubal tonsils near your ears, the palatine tonsils, which are the classic ones you see when you open your mouth and say ah, and the lingual tonsil right at the base of the tongue. When an infection sets up shop in here, it triggers a classic triad of symptoms. We're talking intense throat pain, a fever driven by inflammatory cytokines resetting your hypothalamus, and lymphadenopathy, which is swollen lymph nodes. And honestly, that swelling gives us our very first major clinical clue. Inflammatory debris drains into the cervical lymph nodes in your neck. If a patient presents with anterior cervical lymphadenopathy, so swelling in the front of the neck, it heavily points to Group A Strep or just a general viral infection. But if that swelling moves to the posterior triangle, the back of the neck, that heavily implicates generalized lymphatic involvement, which is a massive red flag for infectious mononucleosis, or mono. Section 2. Viral villains and mono, the deceptive invaders. Let's look at our first group of suspects, the incredibly common, highly contagious, and sometimes really deceptive viruses. Common viruses, things like rhinovirus or adenovirus, spread via respiratory droplets. They hop into your squamous epithelium, replicate like crazy, and then just pop the cells to spread even further. But here's the critical distinction to keep in mind. Viruses don't just stay neatly contained in the tonsils. No, they travel. So a viral infection usually presents with the 3 C's. Coryza, meaning nasal congestion and a runny nose, a dry, non-productive cough, and sometimes even conjunctivitis, watery eyes. If you see these symptoms alongside a sore throat, you're almost certainly dealing with a viral villain, not a bacteria. But there's one virus that behaves completely differently. Epstein-Barr virus, or EBV, the culprit behind mono. It spreads through saliva, but instead of just damaging those surface cells, it actively hunts down your immune system. It uses a highly specific receptor called CD21 to actually hijack your B cells. Once it's inside, it commands these B cells to proliferate wildly and deposit into your lymph nodes, your liver, and especially your spleen, which, by the way, creates a very real risk of a splenic rupture. It also turns these hijacked B cells into these sort of poser plasma cells that just pump out useless, junk, heterophile antibodies. Meanwhile, your T cells go into an absolute hyperactive frenzy trying to hunt them all down. This massive, dramatic immune response, that is exactly why mono leaves patients with such debilitating, extreme fatigue. So the crucial point here is figuring out if a patient is currently fighting mono or if they just had it sometime in the past. To do this, clinicians use an EBV serology timeline. In the acute phase, we look for IgM antibodies. As the infection progresses into the past or becomes dormant, that IgM drops off and we start seeing IgG antibodies along with anti-EBNA, which stands for Epstein-Barr nuclear antigen. Basically, if you see those last two, you're looking at a ghost of infections past. Section 3. Group A Strep's wrath, the brutal attacker. If viruses are the deceptive invaders, well, our next suspect is Streptococcus pyogenes, commonly known as Group A Strep. Group A Strep doesn't just casually bump into cells. It uses M proteins and F proteins to act like cellular Velcro, adhering tightly to the epithelium. Once it's locked in, it releases enzymes like streptolysin and proteases that act like power drills, literally boring holes directly into your cells and tearing apart tight junctions.
This intense cellular destruction immediately alerts your neutrophils, which swarm the area and start releasing reactive oxygen species. This chaotic battlefield of dead bacteria and immune cells creates the classic hallmark of a strep infection, that thick, purulent exudate, or pus, coating the tonsils.
But strep has a secondary, terrifying weapon. It releases pyrogenic exotoxins that act as superantigens. Instead of a normal immune response, these superantigens act like a forced handshake between your immune cells, hyperactivating your T cells and causing a massive systemic cytokine release. This causes a high-grade fever. It can also cause capillaries in the skin to leak, resulting in scarlet fever, which is characterized by a full-body sandpaper rash and a bright red strawberry tongue. And if that systemic vasodilation goes too far, the patient's blood pressure can plummet, leading to life-threatening toxic shock syndrome. Section 4. The threat of diphtheria, the rare assassin. Now we're going to examine a pathogen we rarely see today, mostly thanks to modern vaccines, but one that is an absolute assassin when it strikes the unimmunized, Corynebacterium diphtheria. Let's break down how the cellular devastation unfolds step by step. Diphtheria attaches to a cell and releases a deadly two-part exotoxin. The B subunit binds to the cell, triggering endocytosis. Once inside the endosome, acidification occurs, which cleverly launches the A subunit directly into the cell's cytosol. Once it's there, the A subunit hunts down elongation factor 2 and completely inactivates it. Now, without elongation factor 2, the cell cannot synthesize proteins, and without protein synthesis, the cell undergoes sudden, catastrophic death or necrosis. This mass necrosis in the throat triggers plasma proteins to leak out, which mix with the dead cells and neutrophils to form a dense, suffocating pseudomembrane directly over the airway. It's highly vascularized too, so if a clinician tries to scrape it off, it will bleed profusely. Even worse, if those exotoxins manage to escape into the bloodstream, they systematically attack the heart and nervous system, leading to fatal acute myocarditis or severe neuropathy. Section 5. Red flags and complications, the climax. Because if these infections are left unchecked, they can escalate into some of the most terrifying red flags in clinical medicine. Before we even think about swabs, lab tests, or CT scans, there is one absolute mantra every clinician must remember. Airway is king. If a patient with a sore throat presents with stridor, you know, that harsh squeaking sound when they breathe in, or if they're hypoxic, drooling, or present with a massively swollen bull neck, you must secure the airway immediately. These are blaring sirens of impending total airway obstruction. So why does that obstruction happen? While untreated bacterial infections, particularly strep, can rupture through the tonsil capsule and spread into the deep fascial spaces of the neck, we call these suppurative complications. They form massive pockets of pus or abscesses. A paratonsillar abscess will literally push the tonsils and uvula across the mouth. A parapharyngeal or retropharyngeal abscess will aggressively bulge out the back and sides of the throat. All of these physical masses push directly on the airway, mechanically choking the patient from the inside out. It's a true emergency. Then there are the non-suppurative complications, which are caused by molecular mimicry. Weeks after a strep infection, the antibodies your body built to fight the strep's M proteins get confused. They actually start attacking your own healthy organs that look similar to the bacteria. This is rheumatic fever, defined by the Jones criteria. Your own antibodies attack your joints, your heart, which we remember with the O and the acronym for carditis, cause subcutaneous nodules, trigger an erythema marginatum rash, and even attack your basal ganglia, causing Sydenham's chorea, which results in involuntary movements. This right here, this is exactly why we treat strep so aggressively. Section 6. Diagnosing and treating, cracking the case. We've seen the suspects and the incredible damage they can do. Now let's bring it back to the clinic and crack the case with our diagnostic algorithms. To figure out if a patient just has a viral infection that needs some rest or a bacterial strep infection that could trigger dangerous complications, clinicians use the modified center criteria. It's a point system. You get a point for swollen, exudative tonsils. You get a point for tender anterior cervical lymph nodes. You get a point for a high fever. And crucially, you get a point for the absence of a cough. Because remember, a cough pretty much screams viral. If a patient scores a 0 or a 1, it's highly likely to be a viral infection, so we send them home with supportive care. But if that score hits a 2 or higher, we swab the throat for a rapid antigen detection test. If it lights up positive for Group A Strep, we treat it immediately with antibiotics like penicillin or amoxicillin. And this isn't just to make their throat feel better. It is absolutely crucial to kill the bacteria before it can form those deep neck abscesses or trigger the autoimmune disaster of rheumatic fever weeks down the line.
We've seen how viruses hijack B cells, how strep acts like cellular Velcro to literally bore holes in our tissues, and how the exotoxins of diphtheria systematically shut down protein synthesis. I mean, it's an absolute war zone in there. So, knowing the incredible microscopic battles raging inside your own tissues, will you ever look at a simple sore throat the same way again? Keep learning, stay curious, and I'll catch you in the next explainer.